We will go ahead and get started with our didactic presentation today. As I mentioned, Dr. Quigley and Dr. Courtney Burnett will be joining us, and I see that they just came on the screen. So whenever you are ready, please feel free to share your PowerPoint.
Okay, great. Well, thank you all for having us. We're happy to be back for the second time, and our topic this morning is collaborating with psychologists. I'm a clinical psychologist here at UNM, and Sean Quigley is with me, and he is a behavior analyst, and so we have both perspectives. I know there's some people who also have both credentials, so they can anyone join in and ask questions too, but they may also be able to provide an additional perspective to what we're going to present today. I'll let Sean go ahead and start. He's going to give an introduction.
All right, so in terms of today, some of the things we want to talk about are some objectives listed. So we kind of thought it might be useful to explore some of the qualifications for licensure or credentialing as a psychologist versus behavior analyst and really kind of explore some of those. And that will hopefully set up a foundation as to how you might collaborate and understand the roles each professional might play. So our goal would be that you guys would be able to understand the minimum qualifications for licensure as a psychologist in New Mexico. Keep in mind that those change from state to state. And then the minimum qualifications for certification as behavior analyst. Again, probably most of you know that. But then state 3 similarities or differences between psychology and behavior analytic training, and then hopefully state 3 ways a psychologist and behavior analysts serve individuals with ASD. For a psychologist, and I should say this for all of them, what we're going to review are the minimum qualifications for an individual to practice independently. So that's one of the key differences here at first is that a psychologist can't practice independently until they've achieved the doctoral degree and licensure as a doctoral level psychologist. Within behavior analysis, as you'll see, it's at the master's level where folks can practice independently. So you'll see here that for minimum qualifications, a psychologist must have a doctoral degree. In New Mexico, they have to have 3,000 hours of supervised work, and 1,500 of that can be obtained prior to finishing their doctoral work, but 1,500 of it has to be after the doctoral work. They have to pass a criminal history check as part of the licensure process. They have a professional practice exam. They also have a jurisprudence exam, an ethics exam essentially. And then within your first year of licensure, you have to demonstrate New Mexico cultural awareness. And every 2 years, they have 40 continuing education units. So when we look at now what a behavior analyst, what their minimum qualifications are, again, keep in mind this is for a master's degree, so that's the first difference highlighted in red. Again, notice that it's not 3,000 hours, it's 1,500 hours of supervised work. You don't have to pass a criminal history check as part of the credentialing process with the BACB. Most times employers do that for you, but not part of the credentialing process. As you're all aware, there's a professional practice exam. We do not take a jurisprudence exam. Some behavior analysts might actually be expected to take that, again, depending on licensure within states. Like, for example, I know Louisiana requires that, but in terms of the general credentialing process, it's not required. There is no cultural awareness demonstration for your area or geographic region that you're serving. And then behavior analysts are required to have 32 CEUs a year. So keep in mind, many of you guys know that that was a change that was recently enacted, and it went up. And many people were saying, oh my gosh, this is so much. How are we going to maintain this? Well, just be glad you're not a psychologist in Mexico, because it's even worse. So keep that in mind. So now this is essentially the same thing as this is the minimum qualifications for the doctoral level behavior analyst. Again, you're going to see that most of it is crossed out in red. The large difference is only the doctoral degree. Now again, I understand that the BACB requires some additional things between the BCBA and the BCBA-D, but when you're comparing them with psychology, that doctoral level psychologist, there are these differences still that exist. Again, for me, the large one is the difference of hours that someone might be supervised in their training. And so then you also have to keep in mind that a BCBA-D might also be a doctoral level psychologist. I think Tina Goldsmith at least today on of who we have is one of those people who fit both worlds. So those are kind of the minimum qualifications for that licensure or credentialing. We want to spend a minute now also building the foundation regarding the training that a psychologist would go through versus a behavior analyst. To do that, what we have here is on the left-hand side is the BCBA course sequence requirements, and on the right side, again, is the psychology requirements. And as I go through those, again, one of the things you have to keep in mind is that psychology differs slightly across states because it's a licensing law across states, and it's based off of guidelines from their parent organization, the APA, okay? So if we first start on the BCBA side, you can see that the top one there is ethics and professional conduct. That is also present on the psychology side. And again, depending on which program you went through, the behavior analytic training is likely going to focus on the code put out by the BACB, but it might also incorporate the APA ethics guidelines put out, or that most psychologists experience in their training. Largely speaking, the codes are fairly similar. The next one is concepts and principles of behavior analysis. Again, it's that idea of the specific training in the field of behavior analysis. And so you look on the right side with psychology, they don't have a specific area where they say they have to cover behavior analysis, but those things might come, it might be exposed to the concepts and principles of behavior analysis through human development classes, the logical aspects, cognitive, social. They might get it in multiple areas. Measurement is an area. So a measurement and experimental design are probably most compatible or crossover with research methods on the side of psychology. Okay, but again, I think a difference here is that most psychology research methods are going to focus on group-based research and statistical relationships between two groups and the differences between those to identify meaningful relationships between two variables, whereas the behavior analytic training is going to focus on the within subject or single subject type of experimental design and research and how to measure those kind of things. So again, even though we have similar requirements of understanding research, the emphasis is slightly different. Identification of the problem and assessment probably crosses over well with individual differences and assessment and diagnosis on the psychology side. But again, the idea here, or let me say the main things are probably how do you assess whatever behaviors are of concern, how do you then represent that assessment data, and then how do you move forward on treatment or things like that. Within the behavior analytics side, as you guys are probably aware, it's more focused on individual behavior and identifying how those behaviors are related to environmental variables. So say a functional relationship exists. Whereas on the psychology side, much of their assessment is likely more around specific already classified symptoms, and they're really trying to assess the frequency, the intensity, the duration of those symptoms to fit categories, diagnoses. And so it results in a diagnosis, which then for a psychologist is intended to guide treatment based on the classification of those symptoms, okay? So going down a little bit more, the fundamental elements of change, intervention, and behavior change considerations, again, those are things that a psychologist is likely going to experience within the assessment, maybe diagnosis, the human development coursework, those kind of things, and that's where they'll be exposed to their treatment modalities or perhaps introduced to them. They may also have specific coursework specific to treatment modalities. So for example, they might take a course specific to cognitive behavior therapy or dialectic behavior therapy or whatever it is. And so they might have specific courses just to that, okay? Lastly, that implementation, management, supervision, behavior change systems probably crosses over pretty well with social aspects of behavior or human development. Those can be things like your social psychology classes, your industrial organizational psychology classes. And again, for the behavior analyst, they might look slightly different. You know, there is industrial organization or what we call organizational behavior management. It's going to look largely at behavior change systems. How do you address large systems issues and individual system issues for an individual, how to change those things. Again, notice at the bottom, the minimum amount of credit hours is 270 for a behavior analyst, and it can be roughly 270 to 405 for the minimum requirements for a psychologist across various areas. The thing you have to keep in mind is that depending on the state, it'll say 6 to 9 courses, and they'll give you guidelines on how many of those courses need to be from these certain areas. So for example, it might say you need 2 courses that fit biological, cognitive, or social aspect. So anyway, depending on the state and the program, they may have between 6 and 9 courses, where most of us, for the minimum requirements again, is just the 270 credit, so 6 courses. Okay, so moving forward off of our training, minimum qualifications, it's now let's begin to talk about the practice definitions of what is the scope of practice, generally speaking, for a behavior analyst or psychologist. Within behavior analysis, I'm using the BACB Model Act for licensure as the statement is in terms of what it is that we do. So it talks about designing, implementing, and evaluating interventions to help improve human behavior. If you look at psychology, they're essentially saying the same things with some different words. They're going to observe, describe, implement, evaluate, again, for the modification of human behavior using psychological principles. So at face value, a behavior analyst and psychologists are largely doing the same things, evaluating, developing treatment, implementing that treatment, and hoping for the betterment of that individual and society at large. But I think as Courtney talks, some of the processes by which we do that looks different, and there's different focuses of how we do the design or the evaluation, implementation, and evaluation.
All right, so I'm going to talk just a little bit for the last few minutes about some of the similarities and differences in practice between the 2 disciplines, as well as how are ways that we can collaborate. So kind of broad similarities, and this is really following what Sean was just saying in terms of the two disciplines, is that we both complete initial assessments and really look for treatment goals. We want to find out what's wrong, what's interfering with functioning, and how can we implement strategies or interventions to improve the functioning in whatever area is problematic. We work on treatment goals using evidence-based practices, and so then we're using our research and literature base to really guide what we know and what we've learned to use practices that have the best impact, or that have been shown to have the best impact on that individual's treatment. We both provide ongoing monitoring of progress and adjusting our goals through treatment. And so we're really looking to see what progress is being made, how are goals being achieved, and then what are subsequent goals to either build and develop skills, or then to continue to treat whatever problem behavior is happening. And we both work most typically not just with the child or with the individual, but really with systems within that child's world. So we're trying to impact their functioning most by really understanding their environment. And that can include working with parents, working with teachers, working with other therapists, really to maximize that individual's functioning and to maximize behavior change. So we're looking at a number of variables outside of that individual itself. Differences in practice include that psychology is really, when we do an assessment, we're really driven by kind of diagnosis and using the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, and that came out, the updated version came out in May of 2013, so the revision is pretty recent. And this is what we use to really guide how we define a problem, and also what diagnosis we're using that then we're communicating with other professionals. So it may be with pediatricians, it may be with psychiatrists or other mental health providers, or it may be with a family to really help us put a definition and put a label on a pattern of symptoms that we either see and observe in a child, or information that we gather from that parent or from that child. And it can be historical information as well as current information and clinical observation. So really what we're trying to do is gather a whole set of information to try to identify if there's a diagnosis that's appropriate. And like I just said, that diagnosis can be based on a number of different methods of data collection. It's different data collection than what a BCBA would do, but similarly, we are kind of looking at patterns of behavior and trying to define it. Then typically, and I say this broadly, most typically the structure and intensity of sessions is pretty different. So the psychologist, a pretty traditional model of outpatient therapy would be that child or individual comes in to see a therapist for approximately 1 hour a week, and that therapist would monitor and evaluate and treat that individual for a period of time, let's say 12 weeks, providing ongoing monitoring in that period of time, but seeing an individual once a week for approximately an hour. Within that hour, they tend to work on kind of one salient goal in terms of what is maximally impacting that child. And those sessions can include the child and then may also coordinate with the family and with the parent to make sure that outside of the therapy session, some of those skills can be practiced until they see that individual the following week and get an update on how they've done, what issues have come up, and then what can be addressed in that particular therapy session, and then what are new skills or new goals to work on the week before they see the child again the following week. So in general, the intensity and duration of sessions tends to be quite different. Another thing that comes into play with this is just also insurance reimbursement. For psychologists in traditional outpatient therapy, there tends to be a limit on the number, for many insurance companies, a limit on the number of sessions. And so you just have insurance reimbursement that can be different as well, that can really guide the structure and intensity of sessions. And then, as I said before, the number of goals being addressed. In interventions with psychologists, since we would traditionally just have about an hour, we're going to focus on the most salient issues in that hour, whereas there will likely, with BCBAs, be a number of issues that are being addressed within a session, and a session can be an afternoon or a course of a longer period of time. That can be defined differently. Anything to add? Okay. All right. So I'm sure y'all have seen these two, or this some card that I think is funny, in that it kind of represents all of the lingo and all of the jargon that we all tend to have within our fields. This one being particular to BCBAs and really focusing on the acronyms that are used with data collection and used in behavior plans, and how that gets implemented in a child's treatment. And so this is then contrasted with the psychology one that I found. And this one, psychology faculty got together to make up all that terminology that they use to try to impress everyone, a bunch of Freuds. So two different kind of ways of thinking and ways of approaching behavior, but all very, very much trying to observe behavior, trying to understand behavior, and trying to impact behavior for the betterment of that individual. Just maybe going about it, psychology in a more broad way, and then BCBAs in a more specific way with specific data collection and using that to really guide what you're doing in that particular session. All right. So the last piece is really that we can really maximize an individual's treatment and an individual's progress by collaborating. And so we want to make sure that if there is a psychologist involved with a behavior analytic provider, that there's collaboration and communication between the two providers or any of the treatment team. It doesn't have to just be psychologists and BCBAs. And really you want to understand what provider is working on what goal, and what does that intervention look like across contexts. Really make sure that you're communicating to avoid confusion or contradiction, and also just collaborating so that you can get information on what may be working in one setting, what's not working in another setting, or what is working, and you can really kind of tweak intervention and tweak what you're doing so that child is maximally benefiting from those strategies and interventions that you're implementing. it really also, through collaboration, it increases the chances that you're going to maximally impact that child's functioning, because they're going to be learning the same skills across settings. It may be home, school, another therapy office, or with a psychologist. And you're really going to look to make sure that those skills and those goals and treatments are implemented consistently across those settings, because the ultimate goal is that you want to maximize the impact of what you're working on. And this kind of collaboration can really help achieve that. All right, collaborate again. And another piece of this that I think is really important is that we focus on what that individual needs and what that child needs, but really they're functioning within a system. So another thing to keep in mind that psychologists can really help with is, how are the parents doing and how are the siblings doing? So how is that family system functioning? And what has been the impact of that child's diagnosis or that child's behavioral difficulties? And how are the parents handling the what may be a tremendous amount of stress related to the financial impact of really intensive intervention, of just reacting to and understanding their child's diagnosis or behavioral difficulties that they may be having. Is the parent experiencing any kind of mental health concerns that may be impacting their ability to participate fully in treatment? And really the schedule of therapy, when it's pretty intense, that can also impact a family's functioning, especially if there's other kids involved, in terms of making sure that one child gets what they need and what may be at that time the most important and most important intervention, especially if you're dealing with pretty significant and challenging behaviors. And how are the parents being impacted by that, as well as other children in the family? And I think working with siblings too is another area where psychologists can really help contribute to the team and to intervention, is helping them understand the diagnosis, helping them understand, what may be some of the reasons for some of the behaviors or some of the differences, especially as kids get older and start really realizing and can compare to kids in the similar grades and other classes, that there may be something that's different about their sibling, to help them understand and develop strategies for themselves on really how to maximize that relationship. And then the other piece that a psychologist really could work on some comorbid mental health concerns. We do know that there is a body of literature that really suggests that there's a high rate of comorbid mental health concerns in individuals with autism spectrum disorder. And that can be anxiety and depression are the two primary ones, but it can be other diagnoses as well. So if that is an area of concern, then a psychologist could work on some of those, impacting some of those symptoms, and collaborate with a BCBA to impact some of the other treatment goals or symptoms that may be important to target as well. So I think really the collaboration between these two disciplines is really important and can just be hugely beneficial to the child and the family system. All right, that's what we have. And what questions do you have for us?
And you all can unmute yourself and ask any questions or send them through the chat box.
Joy, are you going to call people out, or should we just speak up? This is Zoe from Santa Fe.
You can, yes, you can speak up.
Great. Hi, thank you so much. My name is Zoe Miguel. Again, I'm from Santa Fe. I'm a licensed clinical social worker. That was so fantastic to really understand some of the real differences between both training, ongoing expertise, and kind of application of the two disciplines. One of the things that comes up often is there'll be a team in the home, there'll be other issues that are being noted by the ABA team, but really trying to get family to reach out and gain extra support through a psychologist sometimes can be challenging. And so I'm wondering if you can speak a little bit about how people can talk about the supports or the benefits of accessing a psychologist to really support some different areas and how that would positively affect the life of everybody. Thanks.
Yeah, absolutely. It's a great question. It's something that as we were developing the slides, we were really talking about, you know, how do you go about doing that? And I think there can be a number of different ways. It could be, you know, just talking to a family about maybe some of the treatment goals and how they can, that there's other ways to impact those treatment goals. And it can be helping the mom, helping the siblings, and that there are different ways of working on things. It doesn't have to be just with the child, but this other provider can really help them and provide a context for them to almost like their own help and own support system as well. So I think phrasing it that it's all meant just like they're getting help for their child, that we know that this is a pretty intense treatment regimen and pretty intense issues that they're dealing with, and that the goal of that and finding someone for them is to really help them as well, so that they can then help their child the best way possible. Do you have other things to add?
No, I think that's great. I mean, one thing you might think about is that, again, with the New Mexico stuff, we have that integrated service plan, which talks about barriers and good things that are, you know, in terms of serving the child. And that ISP really kind of does talk about a multidisciplinary kind of approach to treatment. And so through the ISP process, not just the initial one, but subsequent ones, those might be good opportunities to have multiple people in the room talking about things. Again, getting multiple people in a room, I think. But so then that way you don't have to feel like it's one person always having to advocate and do things. You can easily say, hey, Courtney, you're a psychologist. Here's some of these things we're thinking. What's your thoughts on that? And then they can more specifically address maybe those questions and define how they would do something different from what's already happening. So.
Hello, this is Shireen. I want to say that the presentation was awesome, and it piggybacked off a meeting I just actually left with my team lead. We're doing a presentation next week on benefits of parent training, and a lot of the things that you mentioned kind of went hand in hand with the importance of parent training with children with autism. One thing that you stated that really stood out to me was the interest of the other children in the home and how involving a psychologist in with the family that's receiving services is so beneficial. I want to know, what was your approach to get your company to include both disciplines on a case?
So both disciplines on a diagnostic case or on a treatment case?
On a treatment case, because most of our families that we work with, they're diagnosed by a psychologist, but that's it. We get their ADOS, and we do the ADOS, the VB-MAP, or the AFOS, and we hit treatment from there. Sometimes if we have a client speech or OT therapist that's willing to share their treatment plans with us, we incorporate those so that we can all provide the most effective treatment by being on the same page. But to have a family who receives psychological services as well as behavioral services, it's not too common for us.
Okay. So I think some of it depends. You know, here in New Mexico, the behavior analytic service opportunity is fairly new. You know, there have been companies here historically. We're getting new companies coming in, and the nature of the way that each of those companies are structured, meaning who do they already have in-house to support those children, looks different. You know, and so what we're seeing right now is that in New Mexico, much of the psychologists are what we call a stage one provider. They do the diagnosis, and then everything is off to the behavior analytic company to then do further assessment for treatment planning and for treatment delivery. And so there's already a disconnect there, largely speaking, in New Mexico. So under those conditions, I think part of this today, I think, is to help everyone create an awareness that you probably have to be proactive in reaching out to other providers and really trying to figure out what is your internal system to create these collaborative practices so that, you know, if down the road or whatnot, you have more than just an ADOS with a name on it, a psychologist, that you've reached out proactively outside of children's specific children and you're getting to know them and understand what roles each other can play and how can you support each other, I think that can go a long way to, as you're talking about, how do you make that team work and understand that. If you're a company that has multiple providers already, under one roof, then I think internally you kind of broken down some barriers because they're all in one place. But that you still probably have to have processes to say, okay, are we going to, on some, routine basis, review these cases as a multidisciplinary team, even though like a psychologist may not be doing active treatment of that child, but you say, it's an investment to have that psychologist in a team meeting every 6 months or so to hear what's going on and review. And so they might have the opportunity to say, oh, that's interesting. I'm thinking this. There might be another, opportunity here to evaluate a particular diagnosis that might address some of the data I'm hearing. It's an anxiety-based kind of issue. So for me, that's how I'd look at that. Is probably number one, you got to be proactive. And if they're not a part of the regular treatment team, how do you make them a part of it, at least at some regular basis?
I think the other piece is exactly what you're speaking to, that really in many places there's not a real strong coordination of all of these pieces. Hopefully we're getting there, and with increased awareness of just all the issues that impact children and families, then that will improve over time. I think one of the other pieces is knowing the resources in your area, and there may be resources that address certain areas, and then there may be resources where it's lacking, and where certain either treatments or certain providers who specialize in certain things are needed. But really learning what those resources are and what's available is a big step. Ideally, if there's kind of a coordinated place that can be a resource center, then that's something that can also be really helpful too. So you can call them and just say, here's what I need, who should I call? Some places have that, and some places don't.
Excellent. I think those are excellent questions, and exactly what the overarching goal of Echo Autism and Applied Behavior Analysis is to help increase that awareness and coordination of care across multidisciplinary teams. And I think that this was a wonderful example, and we've seen a bit of that in some of our cases where behavior analysts have reached out and coordinated care with other professions that maybe they previously haven't, such as dentists. And so when we were talking about that previously, we discussed what is the best modality to be able to do so, because our progress reports tend to be sometimes 15, 20 pages long, and when we're trying to coordinate care, we're not necessarily going to be handing those over. So for a psychologist that's working on a focused goal, what might be the best presentation method to be able to do so? I know previously we've talked about maybe just having something short, highlighting and having parents share that during their weekly meetings. From your perspective, what would you think would be the most beneficial?
I think that, it's hard documentation and doing treatment goals kind of in our own language and what's familiar to us in each of our disciplines, and then translating that not only for other disciplines, but then also for families. It's a challenge. And I think just ongoing processes of continuing to refine those and continuing to really hit the highlights, especially if it's being used for a communication method interdisciplinary, for interdisciplinary team, focusing, maybe taking a different approach to that documentation, and what are those main goals that you want someone to know? What are those main concerns, so that then you can address those kind of with the team, so you don't get bogged down in some of the more details.
Yeah, and I was thinking too, in terms of the differences between psychologists and behavior analysts, the behavior analysts are going to have a lot of daily data, and they're probably going to have graphs and all that kind of stuff. And so depending on the training of a psychologist, they may not have as much familiarity with that kind of data and how to view it and review it and see any meaning to it. And there's nothing wrong with that. It's a difference in training, right? But what a psychologist might like is, because you may have data showing how they're acquiring, through different levels of prompting, the ability to go to the bathroom. And so you're showing in the last week, they went from complete hand-over-hand prompting to use the toilet to now they're to some mid-level of prompting, so they're making progress. A psychologist, for a weekly visit may not like that data, but on a monthly basis, what they might like is, like, for example, a Vineland, which perhaps is going to reflect some of those larger changes over time, and they might be able to see some of those scores and see, oh yeah, hey, things are changing here, because that's the tool they use more frequently versus that daily behavior data. And so again, I think working with whoever's on your team, getting understanding of where they're at in their skill set and which way they would want it presented could be beneficial.
Mm-hmm. Excellent point. So communication is key. So does anybody have any other questions related to that? I think that this is an important piece because many of the families that we work with are seeing other providers, and I think sometimes it's difficult to know how to approach the provider, what of information to provide when you do approach them. So definitely feel free to send those along, and I believe that Courtney and Sean might be also willing to continue to answer questions after we can connect with them after ECHO as well if we don't get all of them answered today.
I have a quick question related to the last one. You mentioned the Vineland as a good sort of communication tool talking about progress that both psychologists and BCBA understand. Are there other tools that we share in common? The AFLS was mentioned. I don't know if there are others, maybe the VB-MAP that would be familiar to most psychologists.
For that particular piece, I don't know. I think it just depends on the psychologist there who would be part of that team. Certainly, if they're working specifically and specialized in autism and intervention, then they would have that expertise. But those two would be ones.
So like you say, the ABLS, the AFLS, and the VB-MAP, those are traditional behavior analytic. Most psychologists aren't going to get exposed to those just through their regular training. So when you're talking about, let's just use language, VB-MAP second, the psychologists are going to get exposed to more traditional language assessments like the EPVT, the PPVT, I'm not probably getting those acronyms right, but other language-based assessments, but behavior analysts are probably not going to get exposed to those. And so, again, I think as you develop a relationship over time with different providers, one of the things you guys consider is how do you do some basic cross-training and understand tools that each other uses, and is it okay, like for example, with proper training, could another professional teach a behavior analyst how to use, something like the PPVT as a opportunity to get that data for them that they may not be able to do as regularly, or is that not okay? So anyway, I think it really depends on, you have to work with your team. It might require that you guys might think again as companies, how do you seek professional training, whether through workshops or through school-based credit kind of classes, graduate courses, send your employees back to school for a few niche areas so that you can make collaboration easier if that's the need. So I guess it's hard to say there's one answer to make any of this work.
And some of it may just be with that treatment team asking questions and saying, I'm not familiar with this. Can you explain this to me? And kind of explain some of those points or some of the highlights of what you found. And most often when we can translate it for other professionals and for families, then that is one step closer to kind of getting us on the same page and speaking some of the same language at a broader level.
Wonderful.
So
well, thank you.
Oh, sorry, Joy, maybe you were going to cut off questions. We have our meeting we have to get to. We're running a little bit late, so I apologize. But
Yep, no, we are good. Thank you so much for your time today. We really appreciate you taking the time to share your knowledge with us, and we hope that you have a wonderful rest of the day. Thank you.
Great. Thank y'all. Thank you for asking us, and please feel free to let us know if there's any subsequent questions. Thanks.
Thank you. All right. So if there are any follow-up questions, just feel free to send them via chat, and we can go ahead and follow up with that. But I think that the big takeaway message is that if you're working with a provider that's not within your agency, to be communicating with them and asking them what information they find relevant. I know there have been some providers in the past that have asked to have the behaviors of concern tracked along with the medication changes. So that is one option as well. You can add those medication changes as a phase change line within your behavior graphs that you're already tracking. Being able to also identify if there's additional behaviors of concern that maybe you're not tracking, but that they have identified as a symptom, and then presenting it to them maybe in that larger scale of monthly data, as Dr. Quickly was mentioning as well. So thank you guys for that. And I think that this will actually be a really nice segue into today's case presentation as well. Dan, you will be presenting, and Haley is great. We've got the case up. Perfect. Can everybody read that okay, or should we zoom in at all? Okay, I've got
I can see it fine. Thanks.
Okay, perfect.
So I am Dan Madden. I am living in the Washington, D.C. metro area in Northern Virginia, and my clients are between the ages generally of 2 and 8 years old. We try our best to get the youngest clients. The organization that I am contracting with right now is called Early Autism Solutions, and I wanted to present about one of my cases today that I've been working with for about a year. He has a really interesting profile, and the family and I have been left sort of wondering about how far we should go in looking to independence. Of course, independence is our overarching goal. It is the thing that we want the most for this child. Also the ability to communicate effectively and to reduce his problem behaviors. He exhibits self-injurious behavior in the form of hitting his head on the floor. As you may know, children with trisomy 21, Down syndrome, are very flexible, and he's able to sit down with crossed legs and reach the floor with his head and bang his head on the floor. So again, just to reiterate, we want to know, what should we expect from this child in the short term, but more importantly in the long term, when we're looking into our crystal ball and we're watching him grow up. Because even though he's only 9.5 years old, we do want to start thinking about what sorts of waiting lists we should get him on for adult living, and which direction we should be working in regards to that. So he has a number of other professionals working with him. I've ticked off 2 here. He has he does have an occupational therapist. He has speech and language, and he is receiving a expressive therapy that's located here in Washington, D.C. Well, that's paid for privately by the parents. He also receives those services at school. He's getting them both at school and through his parents' either insurance or private pay. So I have been working off of the materials that was left for me from the previous BCBA in terms of his behavior support plan, and we implemented it, we trained it at home, and it turned out to be extremely effective. So all we've had to do is make some tweaks in terms of timing and to progress him along in some of the prompting timings and some of the reinforcement schedules, and he's doing really quite well with his problem behavior of self-injurious behavior. I guess I'm ready for the next page, please. So this is the section that goes over his diagnoses. He was born with trisomy 21, and I think that it was really questionable whether he would survive. He had a lot of surgeries really early in his life. And you can see here that he had a laryngeal cleft, which had to be repaired, and he is still mitigating a lot of these medical diagnoses on a daily basis. One of the effects of this is that he still has trouble toileting, and he's still wearing a pull-up. it's a little unpredictable. Now, I will say very quickly before moving on that he is somewhat aware when he needs to go to the bathroom and that he's been successful, and we do have a program in place to try to increase his success rate, but there does still seem to be a case where it sneaks up on him and he's not able to request the bathroom or to get there in time. So at this time, pull-ups are still necessary. He's also receiving what they call a chest PT to loosen up the phlegm in his lungs, the mucus in his lungs, so that he can cough it up more easily. And he is also receiving what's it called, the albuterol with the mask and through a nebulizer. And this happens in the morning, and it's a really big part of his morning routine. And it is also happening in the evening right before bedtime. And he's finally, the other really big thing that is depriving him from a level of independence right now is that he's fed through gastrointestinal tube. The tube feeding was put into place because he was frequently choking on solid foods and even liquids. So having even a liquid diet seems to be a bit of a problem. And at this point, he's not even drinking water, which is generally, recommended even for people who are on gastrointestinal tubes. I've had the opportunity to talk to his feeding specialist about this, and at this point, they have backed off of it completely. They may be looking in the future to have him begin ingesting some water every day, but we're not quite there yet. So they are a bilingual family, just to add. They speak Spanish in the home. And they're receiving ABA currently 4 times a week on average for 4 hours. It does vary a little bit from week to week. It depends on his schedule. He's a very busy boy. He has school all day, and then he has his therapies in the afternoon. And on the weekends even, he is fairly busy. And that is one of the times that we try to get in to see him. And that is the time that I focus on parent training. And we've been really active in the parent training model, spending up to 3 hours a week working on specific issues and actually practicing them. And it's been really wonderful. The family is just very on board, and that's, I think, the reason why we've made such tremendous progress. Their mother and father live together along with one of the grandparents. She speaks Spanish, the grandmother does, and that has been a little bit of a barrier, but it has not been, it has not stopped the progress from taking place. But I have had to rely on the mother in general to translate some of what's going on. And then there's a sister who is wonderful and likes to be involved as much as she can, and we try to take advantage of that whenever we can. All right, I'm ready for the next page, please. So the mother used to essentially primarily care for this child. Because of the severity of his needs, she was no longer working and would see to his afternoon activities and make sure that he was getting all of his medical treatments. But recently, because we've made so much progress in his behavior, and because we have the availability of other caretakers to help him transition from school to his therapies, we have, the mother has seen an opportunity to get back to work. And I see it as a tremendous step forward for the family, and it makes me very, very pleased, and it makes me feel like we've done something very significant. But on the same token, it's making it so that we don't have the same access as therapists to the family. They have been sort of valuing their weekends a little bit more, as you might imagine would happen when you have two parents who are working full-time. So that's created a small barrier recently, but I don't expect it to be a long-term problem. I expect that the weekend meetings will continue, and in fact, we are planning to do so this weekend. So, but that is a sort of central part of our therapy. So it's something that I think is really important and was worth pointing out now. And another barrier is, of course, the medical concerns, and that's what the whole purpose of my presentation today is. How do the medical concerns impact our prognosis? So one moment, I just want to make sure I covered everything here. So what the parents have talked about, and we've sat down and spoken together, there are, I think they're envisioning him living in a group home one day. And I think that is essentially what we've been working towards, gaining a level of independence that this child can contribute to a household, do chores, and take care of himself as much as possible, whether it's letting somebody know that he needs to go to the bathroom, once he's in the bathroom, doing most of the work himself, and that includes just getting up onto the toilet. That was something that he used to need help with, and now he's doing with the assistance of a handheld railing. It's important to keep in mind that there are a lot of motor difficulties experienced here. He has small hands, and his dexterity is not great. So when it comes to things like tying his shoes, doesn't seem likely that he's going to be able to achieve that. We're still working on him stacking things, putting things in small items in like stringing beads, for instance, and he is able to do that with concerted effort. He is able to be independent at it, in fact, which was a great step in progress. But as you may imagine, we're still far off from him being able to feed himself because of the medical concerns. But even without the medical concerns, I think there would be a challenge in him being able to coordinate and feed himself. And getting dressed even, I believe, is something that he needs some help with at this stage. And there is one last thing I would like to note in terms of the challenging behaviors. We identified that self-injury was maintained by a function of attention primarily. It was people attempting to stop him from hitting his head on the floor, attempting to redirect him, block him, and that when we put that on attention extinction and literally leave the room, the behavior stopped sooner and happened less frequently. And we were also able to replace it with getting attention, saying excuse me, and tapping somebody or calling somebody by name. And that was the most effective combination of treatments for this particular child. However, he does still exhibit slapping his face when it seems likely that he's experiencing pain. There are particular times when this happens. Right after a gastrointestinal feeding, he seems to experience some discomfort and will engage in face slapping. And when he is getting his chest PT and nebulizer treatment, he does engage in this behavior as well. So we're addressing that. It does seem to also have a little bit of an attention maintain, function at that time. But we're trying to give him additional tools to mitigate that, and that's something else that I would love to get some feedback about. But it seems like we really have narrowed down the focus of the behavior down to that pain attenuation primarily. And I would really like to know if anybody has any questions about the case or any insights or have maybe experienced any similar cases.
Great. Dan, you did an excellent job summarizing the case or presenting the case. And so at this phase, I'll go ahead and just summarize really briefly, and then we'll move on to clarifying questions. So we have a 9-year-old who you have been working with for approximately 1 year. Is that correct?
Yes.
Okay, excellent. Who you've been working with for approximately 1 year. He has a diagnosis of Down syndrome and also multiple medical concerns that have been addressed throughout his lifetime. I must say that your team has done an amazing job working with this family, and very impressed with all of the work that you've done already. In working with the family, it seems that it has been a conversation that has been initiated either by you, the family, or both parties, thinking about how to help him plan for his life, continuing towards independence with the highest quality of life possible. Because of these underlying medical conditions, there are questions about what the best course of action and route would be as you start that planning now. And so what you're looking for today is some consultation from our multidisciplinary team about what are some of those things that maybe should be planned now, and then what are some of those things that maybe to be thought about in the future as well and addressed later on.
That sounds exactly right.
Okay, perfect. So what we'll do first is we start off with questions from our audience participants. So are there any clarifying questions from anybody that is in the audience today? Oh, and if you do, you can unmute yourself and ask at this time.
I had a couple.
Great.
Nice job, Dan. It seems like a really special boy that you're working with, and I can tell you're really invested and care a lot, so nice job. I'm not sure if you explained it, but how is he primarily communicating at this point?
That's a good question. He is able to vocalize. Unfortunately, some of his language is difficult to understand because of the laryngeal cleft, and he has tongue thrust as well. His tongue comes out quite far when he's speaking, which impedes his ability to be understood. His mother can understand him. It's the difficulty with getting that out to the rest of the people around him. He does augment his communication with sign language. This is something that his mother was working on very closely with him, and he does have a number of words that he will say and sign at the same time, which helps us to understand what he's saying. He does not use, at this point, any speech output device, but it is it's something that I have mentioned to the mother that we can continue to talk to his speech therapist about. It may be very appropriate for him because he has really good syntax and a really good vocabulary. He's just not able to express himself very well.
Yeah, right. And you had mentioned functional communication really helped decrease self-injurious behavior, so I got thinking about the pain that he's now slapping himself for too. So I just wondered how he would go about saying that hurts, basically. And then I wondered, like, how is his receptive language at following directions, and how many steps is he able to follow?
At this point, we are able to show that he can do a 2-step instruction. One of the main goals that we have is for him to follow an instruction because he will crash on the couch. He'll say no. He'll refuse. And this is another area where we've really improved. And he can follow now the instruction, let's say go upstairs and get ready for bed. And this was something that they struggled with very much. He would refuse. He would stay downstairs. And it was a lot of effort for him because he would be on the 3rd floor. That's where, this is a really important point that you've brought me back around to. And I'm sorry to take a tangent here, but this is kind of an important issue for his independence. He is still sleeping in his parents' bedroom. This is a subject we keep circling around to, and the reason why they have a bed for him in their bedroom is because when he gets sick, they are very concerned about his ability to breathe, and they want to be able to monitor him to make sure that he gets the help he needs immediately if he has an emergency at nighttime. So they've toyed with the idea. He does have a bedroom with a bed and all of his toys and all of his stuff on the second floor. But they've really resisted the idea of putting him in there unless it was just with somebody really nearby. Now, Grandma lives on the second floor, so she's close by, but I still think that they feel a little bit more of a responsibility to really monitor him. So anyway, that was actually one of our first big breakthroughs, was everybody got on board to have him go all the way up to the third floor and follow a two-step direction. We haven't really toyed with 3 steps yet, so I'm not really sure.
Thank you.
Great. Well, thank you so much. Those were excellent questions, Sarah. And I appreciate you asking those. We are going to move to our panel questions, just so we can make sure we get through that and to some of our recommendations before the end of the clinic. Time flies when you're having fun. And so I know that, Zoe, we had some questions around the parent piece with respect to their overarching goals, and I know there's a lot of the family component, so I was hoping maybe you could start with that.
Sure. Again, I'm Zoe Miguel. I'm a licensed clinical social worker, and so I come from a little bit different perspective in terms of questions. So one of the questions that I had was, what are the family's goals for him now? And in the future, you had mentioned the group home was one of our goals, but in terms of independence and moving out of the bedroom, are those family goals, and how do you come up with those? Or how do you come up with the goals around those?
So this is mostly through interview that I am sort of coming to discover what is most important to the family at any given point. And I can't rely on the Vineland for this because it's really micro managing the situation, and the Vineland doesn't cover that. So what they want right now is for him to get up out of bed in the morning by himself and go to the bathroom. So what I'm trying to do, what we've been using during our sessions that's been very successful, is an independent activity schedule where the child has 3 drawers and he does all of those tasks in a row. And he uses pictures and he transitions with the pictures. So actually this was one of the questions I wanted to ask, and maybe you have some insights. Do you think it would be appropriate to use a picture to have him transition into the bathroom in the morning? Because that's one of the things they want to work on. And another goal is that they want to transition that independent activity schedule into their lives. We've been using it in our sessions really successfully, and they want to be able to use it to keep him occupied on the weekends.
Great. So those are 2 really nice goals, right? One is pretty concrete short term, and the other one, not short term, but concrete in terms of a skill they want him to learn, getting up and going to the bathroom, and the other one is going to really impact their entire lives in terms of implementing that activity schedule. So getting him out of the bedroom, doesn't sound like that's their goal. Is that correct?
They would like to see that happen. They've expressed that to me, but I don't think they think it's a realistic goal at this point.
Okay.
I think they're rightfully a little nervous about it.
Yeah. Have they received any support, sort of going on our earlier presentation, in terms of the trauma that they have been through and having a child that may or may not have survived, and multiple medical traumas and sort of ongoing challenges? Do they get any support?
I've wondered about that, Zoe. I don't have any answer for you. They haven't shared that with me, and I haven't asked, to be entirely honest.
Okay. And then just two other quick questions. The additional support that does he have a home, like a home nurse, a healthcare nurse that's with him that supports him throughout the day? And who is transitioning him from school to home?
Right now, they have hired so the transitions from school to home are facilitated by our therapists at this point to help them with the transitions, because those transitions were difficult. But assisting us, we also have the granddaughter, and we also have somebody who they've just hired who has experience working with children with severe medical needs, who is going to sort of be a babysitter or a respite care worker. So that's somebody who they're paying for privately, but I've actually, in the course of filling out this case presentation, it occurred to me that they qualify for an in-home nurse and also a respite care worker. So I do want to make sure that they are clear on that, because they could really use it. I mean, as you can tell.
Yeah. That's fantastic. Super helpful information. And again, wonderful, wonderful case. And it sounds like you are all doing extraordinary work. So thanks for bringing this to the clinic today.
Thank you.
Thank you, Zoe. In thinking about their network of support and maybe even how to approach them and asking them about that, I was wondering, Sarah, if Sarah Baca, our parent panelist, had some questions related to the support system and any other pieces that they might be experiencing at this time as well.
Well, it seems that am I unmuted? Oh, yeah.
Yes, you are.
Sorry. It seems that they have, listen to the grandma helps them, and they have a pretty good support system, so that's good. I'm really just still trying to take all of this in, and as a parent, thinking about your children and what they're going to become, and knowing that you have a provider that's going the extra mile for them is amazing. So I just wanted to thank you personally for that, because I can imagine being in that parent's shoes and having to be like you, doing what you're doing is amazing. So thank you. I'm so sorry. I'm so emotional.
Thank you, Sarah.
I had a tough weekend with my little guy, and really it wasn't tough compared to what this family's going through. So thank you.
Yeah, thank you, Sarah. And I think that,
that was the question, because I'm just still trying to take it all in.
Yeah, no, absolutely. And, I appreciate, one of the best parts of our panel is having Sarah being on our panel. I know I thought Zoe was reaching for a tissue for Sarah, but I know you guys aren't in the same room. But I think that this is one of the most impactful pieces, is being able to see, the work that we're doing and being able to see the impact that it can have on the families, because we might not always realize that piece of it. And I do agree that your team has really put a lot of thought and care and time into helping this family, and I'm so glad that you're here today with us as well for that reason, and we love you, Sarah. So in thinking about some of the independent pieces, I just had a couple questions that were on the treatment objectives that were outlined here. I know that you had mentioned increased cooperation. Is that related to anything with the medical procedures, or is that cooperation related to the transitions that you wrote about immediately above?
Fortunately, cooperation with the medical procedures is just fine. I think, having done it since he was just very, very young, it didn't become an issue. The only issue that we're having in that regard is the face slapping that's happening around the time of some of those procedures. It really has more to do with his routine. Cooperation with going upstairs, for instance, cooperation with walking to the kitchen. He has very low motivation and is more likely to, like I say, just crash on the couch. That is the behavior that we'll often see when he's asked to move from one place to another or asked to clean something up. So the cooperation goal was written by the previous BCBA, and I've just continued it because it really presents a nice scaffolding for what we're doing.
Okay, and you mentioned that he had low motivation, so does he have relatively few reinforcers?
No, thankfully, because, so many times we look to something like an edible, and I, as much as I try to shy away from that, in this case, I absolutely do not have that option. So we've had to make a lot of good reinforcers for him. We've had to find a lot of good reinforcers, and he has a lot of things he loves. He loves parades, he loves birthday cards, he loves videos, and he loves music. And he doesn't just like kids' music. He likes Johnny Cash, he likes Kiss. He likes a lot of things, and so it's been really easy to find things that motivate him. And the thing that motivates him the most, more than anything else in the world, is spending time with people. So giving him that quality social interaction is the best thing for him right now. Now on the verge, he's 9 years old, and so some of the manner of our social interactions may need to change over time, but right now giving him a big hug is probably the best thing that can happen to him, and has actually functioned as a reinforcer for some really important things.
Wonderful. Oh, he sounds like such a fun guy. And so then with his independent activity or independent play schedule, how is that going? Is he independently following that schedule during sessions?
He asks for it sometimes. He is doing it. And so just to kind of visualize, because they all look a little bit different, this one has a paper schedule on the desk that has numbers 1 through 3 that are Velcro, and he has a set of drawers on wheels that are vertical drawers that are labeled 1 through 3. And he takes the number off of the schedule on the table, he matches it to the drawer, and he takes the item out and brings it back to the table, finishes it, and brings it back. He is doing that with, I'd have to double check, but at least 90% accuracy. The last time that I saw him do it, we just talked the whole time. I was showing the mother how it goes, and realized at the end of it that he didn't get a single prompt from us. He did everything all by himself. So I feel like the less attention you pay to him, the better he does, which is exactly what you want in that case. Even if he drops an item on the floor, he'll pick it up himself, which is a lot of effort for him. And I do want to point that out, that he has to bend over or get up and get the item. So we all sort of stood with our jaws gaped the last time that it happened too, because we had introduced some new tasks that he could do, but we didn't know if he would be able to do it independently in the structure of the independent schedule. And he did amazingly well. It took him almost 40 minutes to do the whole thing, and he stayed focused the entire time.
Wonderful. Okay, great. And then Tina, I know we have probably a lot of questions around some of the other behavior things, but I wanted to pass it off to you as well. Let me unmute you. Oh, I can't unmute you. I think you have to do it.
I think I should be unmuted, right?
Yeah.
Okay. Hi, everybody. Again, I'm Dr. Tina Goldsmith. I'm a psychologist and a behavior analyst. So I ask questions that are all over the place, typically. One of the kinds of questions I think of as a psychologist is really not just sort of where his specific skill levels in different domains, but what is his overall intellectual functioning level? And do you know that? Has there been a recent test from school or private provider?
So according to the testing at school, I attended this last IEP meeting, he is about a grade level behind in reading. And that is actually one of his independent tasks, is that he reads a book. And he is a little more than a grade level behind in math, somewhere between 1 and 2 grade levels behind. And this is an area of particular concern for the parents. They want him to keep up with math because they think that it's going to impact his future settings. In terms of those are the two that I'm really aware of. Was there another area that you had questions about?
Yeah, so it almost sounds as if you're describing a little bit about more his level of achievement. So his achievement testing, sort of that discrepancy between where he sets with age level expectations around academics. And so when I'm thinking about intellectual functioning, I'm thinking about really different types of testing that allow me to have a sense of where some of his intellectual potential might lie. So just so that we can understand what the reasonable expectations are for him around sort of problem solving and independence and sort of language development and those pieces. And I understand that all of that is confounded by some medical issues, but even with the information you provided, it's helpful, right? Because if his achievement isn't lagging so significantly behind, leads me to believe that his level of intellectual functioning may be typical or at most perhaps mildly impacted. So that's good news for this guy, it sounds like.
I'm looking right now to see what information I have for this. I think the only thing I have is a progress summary from school, so it's more of that achievement stuff again. Fortunately, I don't seem to have a good cognitive test for him available right now, but I would concur that he seems to mildly to moderately impacted cognitively. He's able to do things like patterns. He's able to problem solve certain situations. But it's really difficult for me to say, I'm going to be honest with you. I don't know for sure. I have not done the appropriate testing.
Right. Okay, I think that's a reasonable thing. Thanks for clarifying. Just a couple of other quick questions. You'd mentioned, this issue about him engaging in some self-injurious behavior potentially related to some pain or discomfort. And I'm wondering, to date, has there been any care coordination, sort of collaboration with his PCP or GI docs to think about ways to either modify his positioning during feeds or modify the consistency of feeds or any number of things that might reduce some pain or discomfort?
I don't have too much information on that, but it is something that I'm going to start to ask about now. I think that's a really good point because there is a lot of collaboration. Well, his feeding expert, I think, has more to do with the oral motor functioning around feeding. So I would, and I've collaborated with her on a number of occasions, but I don't know that she has the expertise to discuss his positioning during a GI feeding. So I'll approach the parents about that and see if maybe we can come to something. They may already know. They have so much information already as it is. They're experts on their son. So I'll ask, and if we don't have a good answer, then we'll seek one. That's a great question.
Yeah, and I think things change over time, right? I think there's a lot of people from different disciplines who often can be engaged in feeding, right? And they may have a speech-language background and sort of deal with some of the oral motor functionings, or they may have an occupational therapy background and deal with some of the other skills necessary to support feeding. They may be a GI doc, right? Through any number of people could sort of converge around this feeding issue. And so figuring out who's the right person to help tease apart what's going on here can be complex, to say the least, but I think it's good to kind of have that in mind. Depending on what they say, there could be some things that you learn from them that impact the way in which you do parent training to support their ability to either modify a feed or do repositioning or whatnot. But it may also be the case that if there are limitations to what those other team members indicate as recs, that your behavior analytic expertise might come into play with thinking about other things that could be done, from distraction techniques to pairing techniques for something positive with that sort of aversiveness coupled with feeding to ensure that that the overall sort of sum total isn't entirely negative. So I think it's a beautiful opportunity for collaboration, and I'm glad you're open to that.
Okay, that is wonderful, and I'm going to ask about that. There was a change recently in how they were doing their feeding because the parents were concerned about it being discomforting to him. And I believe it had to do with the timing, how quickly they administered feeding.
Yeah.
Which
and
already,
and I think
they had a time to assign.
Yeah.
I believe they made a modification in it.
Right. And I think that what you just said speaks to the way in which that collaboration could unfold, right? So it could be the case that whomever is on his sort of feeding team made a recommendation about how quickly to sort of push that G-tube feed, and the parents are seeing some change, but perhaps the parents may not have the right tools to document some of those behavioral changes that are coupled with this more sort of med-directed change. And so where you might be able to step in is helping to develop a data sheet that the parents can then record data related to behavioral indicators or pain or discomfort with the feeds, so that then they can take that data sheet that you've helped to develop and support their use with back to whomever is sort of guiding some of those more med-driven recs. And so, again, I just think there's so many opportunities for collaboration there, and it sounds like you're open to it and parents are open to it, so that's great. Yeah. There was another question I had, and I'm going to pass it off. Well, one of the questions related to toileting that I was going to ask about is that I saw in the report that he'd had a colostomy. So did he have a colostomy bag, or was that a thing of the past and he's now, his physiology has changed through surgery such that that's no longer needed?
Yeah, he no longer has a colostomy. He is voiding in the toilet. So it must have been something from the past. I pulled that from a list of previous diagnoses, and I believe some of those diagnoses are also repaired and maybe no longer relevant. So I don't know how that impacts his current ability to go to the bathroom, but no, I don't believe that he still has that. It may have been more to do with some of the previous surgeries that he had. There was one in particular where he had to be paralyzed chemically because the surgery that was done was very delicate and needed time to heal, and so he wasn't allowed to move for a period of weeks. And that may have been the time that he was on colostomy. And it may have been other times as well. The poor boy has had like five surgeries roughly so far, and he's going to have one or two more.
Right. Yeah, and the question was really driven by that the diagnoses that pertain to sort of physiological differences in the way his anus is constructed that would prevent him from having a bowel movement as typical. So even if the repair has been made, just sort of potential disruption in sort of early developmental course related to sort of just the physiology of having those bowel movements, coupled with just sort of the behavioral learning experience associated with that, could set him up for, a tough road. And so I think he very much is the atypical toilet training kid, right? And so thinking through what has the history been and what does his specific physiology look like now that either supports or continues to interfere with his ability to control his bowel movements and experience the same kinds of sensations that a kiddo who's developed typically might experience, to then have the right cues to transition to potty appropriately. All of that, it feels like could have been disrupted, right? So the more you're able to kind of dig in and again collaborate with whomever's been involved in that particular course of treatment can really help set up some reasonable treatment goals around the toileting. So again, just another rich opportunity for collaboration.
Yeah, thank you. That's good advice.
Wonderful.
So Joy, I'll pass it back. Thank you.
Thank you. And then I wanted to pass it off to Kathleen as well.
Hi, Dan. Kathleen.
Hi.
Great presentation. I think this is a really relevant conversation for providers who serve children and individuals of all ages. In the beginning of your presentation, you mentioned that he is currently attending expressive therapy, and I was hoping you could share a little bit more about that. I don't know if it's an expressive arts-based therapy.
Well, I avoided, it does actually have a brand name, but I avoided using that because I was afraid it might give away some personal information and some identifying information, but I can try to describe what it is to the best of my ability. So he's attending at a center 3 days a week, and the things that they work on are having him describe. It actually is very similar in many ways, in my opinion, to ABA, to a discrete trial model, where you sit at a table and they're talking with him and asking him questions, asking him to describe things, asking him to sequence cars and tell a story. And right now where he's struggling, and this is one of the areas where we're trying to help him because he's not being cooperative during these, and I can't say that I blame him. He's being asked to imagine something and describe it. And so these are the types of things that they work on. They start with something relatively easy and they work up to the more difficult and challenging things. And that's an area where I've been sort of collaborating with them to mix it up a little bit more so that he doesn't get so frustrated. But so I hope that answers some of your questions. I wish I could tell you more about it, but I was fearing privacy.
Sure. And what prompted the parents to engage? I understand they're under a private pay agreement, so it must be pretty important for them and for him that he attends. What prompted them to reach out and identify this service in particular?
I believe it was word of mouth. I believe that they are connected to a community of people with children with primarily Down syndrome, but other disorders as well. Because I'm finding that I'm hearing from some of those people now. So I think that they have that fish community and
Great. Thank you so much. My last question was, in thinking about future planning, what state programs might he qualify for, specifically for individuals with intellectual disabilities and complex medical conditions? I know you mentioned that he does qualify for respite and in-home aid. I'm wondering if also this might have a case management component, or if you're aware of anything that he would qualify for long-term in the state.
Well, he lives in Washington, D.C., and I know that is sort of a little bit more information than I need to dance carefully here because I don't want to give any information about who he is. But he would qualify for Medicaid, Medicare, and through Social Security. So I believe that is how he can get access to a care provider that is a nurse and or respite. Many of the other children that we work with in this model have one or the other of those things.
Okay, great. Thank you so much.
No problem.
Wonderful. And then Dr. Soul wasn't able to attend for the entire duration. She had an appreciation luncheon with about 50 people that were joining her, so she had to go. But she did have a couple questions, so I wanted to follow up on a few of them related to the involvement of the pediatrician, and if he has a developmental pediatrician that you're aware of that's currently coordinating care across all of the specialists that he's currently seeing.
Not to my knowledge, and I would love to access that type of thing.
Okay, excellent. And then I think that we have also hit upon the home health aide, but she was requesting whether he had a home health aide or some type of personal care aid. And I know that because the mother recently went back to work, I was thinking that maybe that was something that had recently been incorporated into a schedule. So I wanted to just clarify.
Yes, he does have a home health aide, but what I want to suggest to parents is that they may not need to pay for it. I believe they found this person on their own, and it's somebody who, again, I think came through that network of people who they know in the community who have impacted children, and I want them to be clear that they may either be able to get a stipend or they may be able to have a care provider. A care person provided to them, a trained nurse to come into their home.
Mm-hmm.
So it exists already, but I want to think about their longevity in doing these things and being able to make it cost efficient for them.
Mm-hmm. Okay, wonderful. All right, well, thank you so much. We are going to go ahead and spend the next 20 minutes with our recommendations. What I'd love to do is ask the audience that's participating if you have any recommendations that you would like to share. If you wouldn't mind putting them in the chat box, and then what we'll do is incorporate those within the written recommendations after the clinic. I also had received an email recently inquiring about the written recommendations. All of the recommendations are made available on our website after the clinic. Usually they're posted 1 week after the clinic, but they're emailed out to the they're also emailed out as well within the same survey to the CEU. That's done on Mondays, and then you'll get it separately as well, Dan.
Thank you.
So if you want to put those in, we would appreciate it. And in thinking about our recommendations, Zoe, would you like to go ahead and start first, since you started off with our questions first? Oh, I'm sorry. Do you want me to unmute you? Let me see.
There we go. I was actually just trying to go online and see if there was any type of group or organization that could help both you and the family understand the services that may be available to them in Washington, D.C. Does the family have private insurance?
Yeah, they do have their own private insurance. I'm sorry, I had to hesitate on
That's
that.
okay.
And again, I guess what this child and other children like him in Washington, D.C. qualify for is something called the Katie Beckett waiver, which makes him as an individual
I know.
apply for SSI. Right, exactly. So that's what they're employing right now to access services.
So again, this differs from state to state, and forgive me, I'm in New Mexico, and so I don't. But I know that that law in particular, what it does is that if you have a significant disability that impairs your daily functioning, you automatically qualify for Medicaid. And so whether that acts as your primary source of insurance or your secondary, as a supplement, then you have access to that, which is a very, very big deal. So through Medicaid, my understanding is that the family can have access to what's called a care coordinator. And so that person should be able to help with all of the respite, the home health aid, any services that child qualifies for through Medicaid. They may or may not be able to speak to the private insurance piece, but he may also be able to access a care coordinator through the private insurance. And that may be a very, very valuable tool both for you and also for the family. And Joy and Kathleen, maybe you guys can talk a little bit about how that has helped families that you work with, because I know that has been a big piece of the care that you provide. So that would be one piece. And if you want to touch base with me, I can talk to you a little bit more about that. It's kind of an area that I specialize in. So if you want to reach out to me directly, I'd be so happy to talk to you more at length about that. I guess it's the social work piece for me, and again, Sarah can probably touch on this as well, but I think a lot about what this family has been through, and I think that you have such wonderful sensitivity to what this family's strengths are and kind of what their history has been. But the amount of medical trauma that this little guy has gone through is really profound, and sounds like he's going to continue to have those issues in his life, and how that affects the family and their ability to adapt to his growth, right? He's 9 years old, and wanting to keep him really close for his own safety. And I just can only imagine, it's going to make me cry too, so, you know, what that's like for them.
Yeah.
And so I think, you know, balancing that piece between what they can do now, both in terms of therapy, but also in terms of things they're allowing in, that they're having family time on the weekends, and that they're really trying to normalize their lives in ways, as you said, is so wonderful. I think it shows that they are really getting a lot of the support that they need to be able to allow that in and not just always be on high alert all the time. So I guess my recommendation would be to, and it sounds like you're doing a lot of this already, is to try and balance those sort of what's going to empower them, what's going to develop that self-reliance in the moment, right, or in the next week or month or year, as it relates to the larger goals. I mean, it may be that, you know, thinking about a residential placement, is a lot with a kiddo that's medically fragile and who's 9 years old. But you being able to hold that bigger picture for them and helping them to kind of walk through reaching there step by step could be just amazingly helpful to them. In addition to maybe getting some more supports as they're open to allowing other people to take care of him in the home. And I think that would be sort of the two pieces. The third would just be that community. Oh, that little guy, to not have a real functional ability to express his feelings, his pain, his desires, his wishes, has got to be incredibly frustrating, or at least I would imagine is incredibly frustrating for him. And there are some great augmentative technology, and there's probably other people on this panel that can speak more eloquently and more directly to that. But I know even for kids that I've worked with who are cognitively very challenged and have limited ability to communicate, which doesn't sound like this guy, that having an augmented technology that can, just jump over those barriers can make a huge difference in terms of developing self-reliance and empowering him. So anyway, I hope that's helpful. And again, thank you for bringing both the information and the heart and all of which that you are providing for this family.
Thank you, Zoe. You described the problem more eloquently than I did. That's exactly what I needed your help for, and thank you very much. I do want to just say that functional communication piece is my most important thing as well, and the parents and I have been discussing that a lot lately, and it actually is a source of a little bit of frustration for me that he doesn't already have something like this, because I think that he's very capable of doing it. So it's one of those jumping through hoops and his other professionals in his life that would be coordinating that, getting on board with it. And so many times people say, well, he's verbal, he's vocal. Why are we going to go down this road? But he needs it. He needs to be understood. He needs to be understood by everybody. And I think if we give him that voice, he's going to have a lot to say.
Huge. And the insurance piece may support that because they may pay for it. In fact, I'm almost positive they will. And so that might be a bridge, in terms of it not being a burden on the family of like, hey, this is available. Why not try it?
Great. Thank you. Sarah, I'd love to hear your perspective, recommendations as well.
So, let's see, am I unmuted? Okay, sorry. I guess just, continue to be a positive light in the family's life, because, thinking of residential care, I couldn't imagine, what that feels like, but just continue to encourage them that they are making the right decision. I'm sorry, I have a puppy in the background. I don't know if you can, because I needed something else in my life too. But anyhow, so just continue to be a positive, positive and shine hope on the situation, because sometimes as a parent you lose hope, and it's then that you kind of sink into a hole and kind of isolate yourself. And I think that that's one of the worst things that you could probably do as a parent. Reach out to maybe an organization that has activities in the area to meet other families who may have a child in a residential facility. And if they don't want to do that, there's a possibility of connecting them, if the family agrees to meeting them, meeting another family. I know I meet families all the time that have their children in residential facilities, and they love to share their story and how, what they've learned and what they haven't and things like that. So that would also be one of my recommendations. And again, just for everything that you're doing.
Thank you, Sarah. And I think that that's an excellent recommendation to connect them with other families. We have a couple of toolkits as well that will be sending to you. One of them, actually both of them are from Autism Speaks, but one of them is related to the home and community settings, and they go through the different types of potential settings. It actually also goes into the discussion of funding as well, and even starts to discuss some of the new under the ABLE Act and helping families start plan in the future, as well as you were mentioning, I know, thinking about the types of wait lists that they might need to get on to now. And I know in the state of New Mexico, some of our waivers are 10-year wait lists. I think, Tina, you probably would be able to speak to that wait time as well. And so we'll send that to you because I think that that will also have different questions that they can think about when they're looking at these housing agencies. And I know that with one of the residential communities that I've consulted with in the past, they did have adults that were had multiple complexities, and their aides were working with them, checking on them even throughout the night, every hour on the hour. And so depending on the facility and interviewing the different types of facilities and knowing the right to ask and the support that they're going to have in place, and will be important for them to, have an outline of what to look into. So we'll send that because I think that that's a lot of the questions that they currently have right now is, what should they even be looking at? And then there's actually another toolkit that breaks that apart even more. That's a financial toolkit. And it really gets into, how to cover the costs of these, everything too from the other expenditures that the child's going to have as they age within these facilities. So we'll include both of those. And then I'll speak to the one piece of it, and then I'm going to turn it over to Tina for the self-injurious behavior piece that she was also highlighting during the initial conversation. But I'm thinking about the attendance. You are absolutely on the right track, and it's wonderful to see the different pieces that you're already incorporating with the goals, looking at increasing his ability to complete longer chains of independent activities. He's got a great number of leisure and preferred activities, which I think is wonderful as you're looking at teaching these skills. And looking at transferring that independent activity schedule into his daily life. That's absolutely wonderful next step, especially because we all use activity schedule. That's a great beginner learner schedule. And so for thinking about the parents and that parent piece that it seems like you're really bringing, helping them to think like a behavior analyst essentially in those next steps, because essentially they're going to be with him and helping teach, coming across these new challenges as he continues to age, as he goes through puberty, as he's developing independence in other areas. And so as Zoe was mentioning, Tina was mentioning, things like them being able to collect data, knowing to collect data to then present to their team members that they'll be working with in the future. I think working with them to generalize those skills so that they're able to be able to analyze these new situations that still might have the same underlying function, or when you're looking at teaching independent living skills, going through the same teaching steps, and knowing that they can generalize what they've learned to other skills with him, I think will help them feel empowered, even more so than they already probably do, because it sounds like you've really been working with them well. And then the other piece, because they are working with another agency 3 days a week, the other agency is seeing them multiple times a week. I don't know if you're currently coordinating care with that other agency, but it also seems that coordinating care with them as well as the school with that communication piece would also be probably really beneficial, to be making sure that everybody's getting on the same page with what is the alternative communication method that they're prompting. If one person's prompting more vocal language and there are articulation issues, and another person's prompting sign language, and then maybe somebody else is thinking about another communication modality, it'd be helpful to get everybody on the same page with respect to that piece, because he does have so many providers. So I think that would be really helpful. And then Tina, I know that you have a lot to add to with respect to some of the functional communication and the challenging behavior and the other pieces as well that you were discussing.
Yeah, I mean, I don't think I have any, well, first let me back up and say, I just want to give big kudos for a couple of things that I heard, in addition to what everyone else has already pointed out, and that's just your mindfulness around delivering behavioral analytic services in a really ethical way. And this is at the forefront of my mind just because we had a big ethics discussion recently in my company, and it's easy to stop, to not think about protection around confidentiality, which you were mindful to do a few times today. And I think even when you were talking about thinking about identifying different delivery of physical reinforcers for this kid as he's getting to be, shifting from a 9-year-old into sort of early adolescence, those kinds of ethical things are not things that everybody thinks through. And so the fact that you're doing that really is a testament to your skills as a clinician, and I just wanted to put that out there that I noticed. As for Rex, I think you're doing a lot of the right stuff. I mean, I think for me, this is just about that care coordination piece just being so critical. I think the hard part for us as behavior analysts is we often know that we need to do it and we should do it, but how do we get paid to do it, right? And so I think if you can get that somebody identified through the waiver mechanism on board as the identified care coordinator, that will alleviate a huge burden for you to do that, right? In the absence of being able to do that, what do you do, right? Do you still have sort of this ethical imperative to step up and effectively care coordinate in the absence of another person? And I think to some degree, perhaps you do. I think securing consent for release of information for everyone involved in the case, and then either trying to get a meeting where everybody sort of sits around the table or sort of going stepwise through the list of folks that are involved makes good sense to me. I think that there are just so many limitations to your ability to set realistic goals given some of the medical complexities that you'll always feel a little like your hands are tied behind your back because you've got that information from those people. And then once you've got it, you'll be able to refine those goals and move forward with a lot more confidence. And that's everything from that sort of pain and discomfort piece related to the feeds, to understanding the physiology related to toileting, to understanding what equipment for monitoring might be available for nighttime sleeping to reduce parental anxiety around that separation, just literally everything, including decreasing response effort. And I think that was one of the other recs I just wanted to highlight is that, this guy, we talked about motivation, but sort of motivation is that sum total of sort of all that negative stuff like response effort, right? Coupled with sort of the reinforcers that are on the other side of compliance or successful execution of a task. And this guy's response effort to execute on very basic things because of some of his physical constraints is huge. And so I think the question that I would just challenge everybody on the team for him to think about is, can we just get around that by modifying the expectation for this guy, right? Like, is it still reasonable to assume that he do this task in this way? Or can we give him adaptive equipment, a different type of toothbrush, or different shoes? Does he need to tie his shoes, or can he just wear some slip-on sneakers, right? Like, I don't wear any shoes that I have to tie. Literally, I don't have any shoes that I have to tie. So I think, just think about what can we do to just pull down the response effort for this kid so he encounters a lot of success in what he is able to do and what's reasonable to expect given what life has sort of dealt him, I think is key. And I know we're out of time, so I'm going to leave it there.
Thank you, Tina.
Oops. I'm going to pass it on to Kathleen as well.
Great. Well, I know we are almost out of time, so I will leave you with something to think about more than a recommendation, but really for everyone. I always think about the siblings in these cases, and it sounds like this family in particular has a great support circle. I don't know how old his sister is or what her individual support looks like, but especially when you have a sibling with intensive needs and the parents are up in the middle of the night tending to medical concerns, it has to be scary as well. So I don't know how the sibling is processing it or what her supports are, but I know there are some great support groups for siblings with individuals who have a brother or sister with medical complexities and intensive needs, and so I just wanted to put that out there as well.
Thank you. I will wrap that into a conversation about the support that the parents are getting as well, because I care that they're looking at themselves a little bit more too.
Excellent. Excellent point in addition, Kathleen. Thank you so much. And it has been an absolute pleasure to have you join us today and present. And we really thank you for creating this learning opportunity for all of us to be able to discuss a medically complex case as a team and to be able to think about all of these pieces. I hope that you feel like you got something out of this conversation, and I know that all of the participants in the audience today is walking away with a lot of knowledge just about the different types of complexities that they might encounter when working with families in the future, but then also different things that they need to consider and think about when they're working with families that go outside of treating the child alone, but treating the child's family unit as a whole. So we really appreciate you taking the time to be with us today.
Thank you. Oh, I closed it. Oh, I am still connected. Well, thank you all very much. I thought that I closed the whole computer down. thank you for allowing me to present today. And it was all some really helpful information to help me get organized in my thoughts. So I appreciate it very much.
Well, thank you. I hope everybody enjoys the rest of their Thursday, and we will see you for our next Echo Clinic.